Right, well, this afternoon we welcome you all. This is one of our main events because we have been determined to be a source of information and education for foreign correspondents working in New York and throughout the country. So we like to bring you conversations that deal with significant issues and presented by very, very professional and extremely active participants. So we have a board of panelists that will be introduced to you. We welcome you. This is one of our first events that is going to be focused on issues. And so please stay tuned and make sure that you come to the other events. Thank you very much.
Is it working? Excellent. Ladies and gentlemen, very good afternoon. I'm Atul Singh. I'm the founder, CEO, and editor-in-chief of Fair Observer. Now, many of you may think, what is this Fair Observer? Malarkey and all that. Well, it's very simple. Fair Observer is a world news organization. It is a non-profit. You can consider us an alternative to The Economist, to Foreign Policy, to Foreign Affairs, Le Monde, and similar publications in the ilk. The big difference between what we do and what others do is that we have a bottom-up approach, a democratic approach to news, which means that anyone and everyone can write for us, but everyone goes through a stringent editorial process. That involves fact check, that involves style check, that involves some people rewriting their articles 11, 12, even 15 times. I take my hat off to whoever it was who did that. Obviously, I can't reveal the name to you. So we have 2,300 plus writers from over 85 countries. On the one end of the spectrum, we have 3 Nobel laureates. On the other end of the spectrum, we have teenagers from Gaza, we have young women doctors from Nigeria, and we have some of the best minds from the developing world or emerging economies, howsoever you want to term them. A lot of these writers have been trained by us because, as you know, if you want finished products, you can go to Oxford or Cambridge and hire all your reporters, which is what The Economist does. Our motto is that we won't send someone off to report on India after a semester of South Asian studies at Harvard or wherever. Our motto is very simple, that if you want to report on a place or analyze a place, you must have skin in the game and dirt under your fingernails. But many times the people who do have dirt on their fingernails don't have the polish. So we have trained a lot of our people, and therefore we've drifted not just into journalism but education. And we've run workshops, including the Voices of the World program that taught over 400 people in 6 countries, India, Kenya, Morocco, Mexico, Austria, and the US. And that is what we do. And I'm very grateful and honored to Nancy, to Thanos, to Marilyn for giving us the opportunity to take part in the discussion. I am your moderator. I will crack the whip when it comes to time. We are under quite stringent time limitations. Without further ado, let me introduce all of you to our very distinguished panel. First, we have Magdalena Cerda. Correct me if I'm getting the pronunciation. Yeah, right here. Correct me if I'm getting the pronunciation wrong or right. Wrong, actually. She's associate professor and director of the Center of Opioid Epidemiology and Policy at the Department of Population Health at the New York University School of Medicine. She went to Harvard University School of Public Health and is a former Robert Wood Johnson Health and Society Scholar. She has only 150 peer-reviewed publications, so she's clearly not working hard enough, and only 6 book chapters, not 25. So there's room, of course, for a more skyward trajectory. She has been continuously funded by the National Institutes of Health for the past 15 years. So welcome her with a big hand, a very eminent personality indeed. Thank you for being here. Second, we have Robin Kerner. He is a Senior Project Director for Healing Community Study and an Associate Research Scientist at the Columbia University School of Social Work, Social Intervention Group. He oversees and implements an $86 million NIDA-funded study to reduce opioid deaths. He was a broadcast journalist, became a clinical psychologist, and has researched treatments for alcoholism and depression. Ladies and gentlemen, welcome Robin. Welcome Robin with a big hand. And then we've got Josh D. Lee, Associate Professor, Department of Population Health School of Medicine, New York University, Director of the New York University Fellowship in Addiction Medicine, a clinician researcher focused on addiction pharmacotherapies in primary care and criminal justice populations. Again, someone who's done multiple NIH clinical trials and is an expert in the field. So Josh D. Lee, yes. So could I request the three of you to come here? Perhaps so that might be better, or yeah, that might be helpful. Thank you. So, welcome all of you, and I'm going to hand over the mic because this is being recorded, so that everyone can address. I have some questions straight away for you, John, without further ado, and I'm going to fire off a couple and then perhaps follow up. And the question I have is that we know, to give a background to everyone else, that the opioid epidemic is a bit like the opium addiction a century and a half ago in China, ironically. Since 2002, pain management apparently has become the fifth vital sign in the US, in part helped by aggressive marketing of synthetic opioids. We know there is a very high prevalence of opioid use disorders. And the question is, for us, is to examine what is the problem and what might be the solutions to the problem. And so, John, without further ado, what are the differences between, let's say, medication-assisted treatment for opioid use disorders, and what do you think what does this data say about treatment success?
So treatment, I think, is actually one of the least well understood and probably the most misunderstood aspects of the opioid epidemic. And I think there are a number of reasons for this. I mean, one is stigma, which pervades the whole field. A second is the kind of historical separation between mainstream healthcare settings and the addictions specialty care settings. And the third is the fact that there just simply isn't really an understanding of how these medications work. There are really three FDA-approved medications for addiction. One is methadone, which is a full opioid agonist. Second is buprenorphine, which has come out much more recently in the last 20 years, which is a partial opioid agonist. And the third is naltrexone, or extended-release naltrexone, which is marketed as Vivitrol, which is a full opioid antagonist. And one of the things that's confusing about it is here you've got a disorder, opioid use disorder, that is treatable with medication like methadone that really substitutes or replaces the opioid that people are addicted to. Or at the other extreme, naltrexone, which is a full antagonist that blocks the effects. And buprenorphine is very much in between them. As a partial agonist, it has some effects on the opioid receptor that are opioid-like, but that aren't as complete as methadone, which is a full agonist. And as a consequence, buprenorphine is both effective in treating opioid dependence and at the same time will prevent overdoses if people take opioids. Naltrexone, on the other hand, doesn't have any opioid-like effects, but at the same time blocks the effects of opioids. So there's a lot of confusion in the field about the differences. They're pharmacologically quite distinct. They are, in terms of logistics, they're quite different. People have to be fully detoxified to start naltrexone. They can start onto methadone while they're still taking opioids. And they can start on buprenorphine after they're in some degree of withdrawal, hours to a day or so after taking a last dose of opioids. There are real differences in terms of the way these are perceived. There are people who are quite uncomfortable with the idea of using agonists to treat opioid addiction because it's perceived as being substituting one drug for another, and there are kind of moralistic views about that. There are other groups that have been very much pro-agonists. The methadone field has been very much pro-agonists and have largely felt that antagonists aren't going to be effective. So, go ahead.
Can you explain to the audience what is the difference between agonists and...
Yeah, so an agonist binds to the opioid receptor like morphine would or opium, and activates the receptor and does at the and by activating the receptor causes opioid-like effects. It causes the high, it causes respiratory depression, it is effective in relieving pain. Whereas an antagonist binds to the same receptor but has no efficacy at the receptor. It doesn't do anything to the receptor, but by binding to the receptor, it blocks the effects of opioids. Does that help you with that? Yeah, okay. So. No? You can hear? Okay. Okay. All right. Well, I'll try.
It's not part of the speaker
Yeah.
system in the room, it's just
Yeah.
for the video.
Oh, okay.
So we'll
So
speak up.
maybe
None of
that
them
one
are
isn't any
right.
better. Okay. Then no wonder. Okay.
Let me very
Yeah.
quickly follow up. So you said there are moralistic fears about treatment. But what about the practical side, in the sense that are these covered by insurance? If not, let's say how much would it cost per patient in New Hampshire or New York? Or any
Yeah.
of these
So in some states they're covered by Medicaid, in others they're not. Magda is probably the person who can speak much more knowledgeably about that than I can. But the range of costs for these medications is from $100 or $200 a month up to about $1,000 a month for some of the long-acting injectables. I mean, the differences include not only the pharmacologic differences being kind of opposite effects pharmacologically, but that one the agonists continue maintenance and continue dependence on an opioid. They're associated with withdrawal when they're discontinued. They're subject to regulatory restrictions and subject to diversion, whereas the antagonists don't produce dependence. They are not associated with tolerance, and they're not associated with any regulatory restrictions on use. So systems like the criminal justice system in many states, and Josh can speak a lot about this, are very much against agonists, but are comfortable using antagonists. And yet there are other groups that would be much more favoring an agonist approach.
That brings me on
Yeah.
to Magda.
Yeah.
It would be great if you could enlighten us about the evolution. Give us the picture. I should have probably started off with you of the opioid epidemic itself, starting from the late 90s, broad brush, stroke 2010, heroin, 2013, synthetics, and then get into some of the points that John raised.
Sure. So right now, drug overdoses are the leading cause of accidental death in the United States. We know that drug overdoses, in fact, tripled in the last 20 years. It's a huge increase. And it really started, the current opioid crisis started at the end of the 1990s with when there was a surge in the use of prescription opioids to treat non-cancer pain. And with that surge, quickly followed an increase in overdoses due to prescription opioids, so painkillers like oxycodone, hydrocodone, that kind of thing. So that was at the end of the 1990s. We saw a gradual increase. It started to stabilize around 2010. We started to see that overdoses from prescription opioids started to stabilize as states started to restrict access to prescription opioids. But at the same time that access to prescription opioids was restricted, the prices of heroin dropped, access to heroin became more available, and as prescription opioid overdoses stabilized, we saw a surge in overdoses due to heroin. Then around 2013, we saw a shift where there was a surge in overdoses due to illegally manufactured synthetics, like you've probably seen, like fentanyl or carfentanil. At the current time, we've seen some provisional data suggest that rates have stabilized. So around 2018, we saw some stabilization in the overdose rates, particularly for prescription opioids and for synthetics, except for fentanyl. We're still seeing an increase in fentanyl. So it's still a huge problem, huge contributor to death and to morbidity in the United States.
And what would you say precipitated the crisis? Is it marketing? Is it prescription?
Yeah.
Is it rust belts, the loss of jobs?
I think it was a perfect storm of multiple things happening at the same time. Part of it, I think, was this push, rightly so, to consider pain as the fifth vital sign, but also accompanying that, particularly the call from professional associations to use prescription opioids as a way to treat, as a humane alternative to treat chronic non-cancer pain. Accompanied with that, there was a push from the pharmaceutical industry to consider opioids as a safe, non-addictive alternative way to treat chronic non-cancer pain. And so I think that both of those together, the concern about chronic pain and the push from the pharmaceutical industry really led to a surge in the use. And you can see, if you just look at the numbers, there was really a surge in sales of prescription opioids. At the same time that was happening, I think there was the problem of deindustrialization, lack of jobs, particularly in more rural and exurban areas. And so there was this vulnerability of people who were suddenly out of jobs, or in areas where there was a high concentration of manufacturing, service industry, where people were more prone to suffer from physical injury, and there was this drug available to treat physical injury. And so all of that combined, I think, led to a surge in the problem of misuse of opioids. And with increased supply of opioids used medically, there was also a lot of diversion of those opioids to families and friends, and that got it all started.
So, correct me if I'm wrong. What you're saying is that supply went up and demand went up at the same time. And in a way,
Exactly.
it was a vicious cycle. There was supply-induced demand and demand-induced supply.
Exactly.
They followed each other.
Right, and even now today, I think all of these three waves have been a perfect combination of supply and demand, right? As the nature of the opioid supply changes, then we see a shift to heroin, then we see a shift to fentanyl. And that also, I think, partly explains why we see concentration of overdoses in certain areas of the country where there is high demand and there is also high supply.
So who is affected and why?
Yeah, so traditionally, before this current opioid crisis, you'd see more opioid use traditionally in urban areas, particularly low-income minority neighborhoods. But with this current opioid crisis, what was really interesting is that there was a shift, right? And so you saw more concentration in rural areas, in exurban and suburban areas, more concentration among whites, among women. And the question is why that is. And so I think part of it was, particularly you saw the concentration as the epidemic started out in rural areas among white, low and working class groups. And so I think it was increased, part of it was that we know that the pharmaceutical industry systematically marketed certain areas of the country. So I think part of that was marketing, part of it was access to prescription opioids in certain areas, and part of it was this issue of despair of areas where there was a lot of deindustrialization, where there was lack of access to jobs, and opioids were used in a way to self-medicate symptoms of distress associated with that.
So what can we do now? Because we heard John dwell upon a few policies, and he talked about the difference between two sorts of drugs, agonists and antagonists, and pointed out which states have warrants. But the question is, are the current policies working? If not, what next? Do we legalize opioids like marijuana? Is regulation the answer? Are jobs the answer? Or are there a whole range of answers? Possibly
Yeah.
there is no silver bullet.
I think it's a whole range of answers, right? I think there's no one solution to this problem. The federal government and states are investing tons of money, investing millions of dollars in addressing this problem. It's probably likely not enough, but I think it needs to be a multi-pronged response. Part of it needs to be, as John was saying, increased access to evidence-based treatment for opioid use disorder, not only in specialty care settings, but in primary care settings, and particularly targeting vulnerable populations, such as justice-involved individuals, like the work that Josh is doing. I think that's a major priority. And for example, as John was mentioning, for example, Medicaid expansion is I think, a huge policy lever to address that. We know that states that expanded access to Medicaid, we saw a subsequent increase in access to medication for opioid use disorder, and there's some signs that we also saw a decline in overdoses. So access to treatment is huge. Access to naloxone, so making access to naloxone easier so that it doesn't require a prescription, so that pharmacists can easily dispense it, is a huge priority. Investment in prevention, so that you stop particularly young people from starting to use prescription opioids and then transitioning to other types of drugs. And I think also, as we're seeing with all the lawsuits, regulating the pharmaceutical industry and regulating the type of marketing that the pharmaceutical industry can do, I think will be important for this crisis and for subsequent crises that might be coming down the line.
So it's funny you should come to pharma last. I would assume that you probably have to take on big pharma just like you took on the tobacco industries, because surely if you say it's about demand and supply, yes, you've got to address the demand side by treatment, mitigate the demand, but you also have to cut off the supply. You've got to make sure that if people do get these, they get these at a higher price, that there cannot be advertising, that there are signs such as smoking kills or opioids kill. Surely that has to be part of the solution, correct?
I think so. So we've looked at the data about pharmaceutical industry marketing, particularly marketing to physicians, and the impact that that had on prescribing of opioids and in overdose deaths. And we did find that physicians who are more likely to receive payments from the pharmaceutical industry were more likely to prescribe opioids later on, and that did have an impact on overdoses. So I think regulating the extent to which the pharmaceutical industry can market or interact with physicians should be a key priority, especially right now in the crisis that we're in. I think potentially doing away with all marketing from the pharmaceutical industry to physicians around the topic of opioids should be, I think, would be a good way forward.
I think that's a very important point, but the other point is that the availability and manufacture and sale and prescribing of pharmaceutical corporation manufactured opioids has actually been coming down since 2010. And where there's the increase in supply and the sharp lowering of costs is all related to illicit opioids. Heroin prices have come down by really an order of magnitude in the last 10 years. And fentanyl, which didn't exist on the streets 5 years ago, is now coming into the country. Fentanyl is 1,000, and carfentanyl may be 5,000 times as potent as heroin. So tiny, tiny little amounts that are mostly being manufactured in China. And Atul, mentioned the opium wars, the British import of opium into China in the 1820s. Yeah.
Indians in addiction for the Chinese.
Right, to normalize to reverse the imbalance of trade between Britain and China. But now most of the fentanyl is being produced in China, and it's coming in, and it's the fentanyl and the heroin are all being sold illicitly, and it's the supply of that, not the supply of pharmaceutical manufactured opioids that is driving this.
So just to create a little controversy, I completely agree with you, but I do think that while we need to clearly be doing something about the supply of the illegal market, at the same time, we shouldn't forget about prescription opioids. And the reason is because prescription opioids, even today, are one of the most commonly used types of opioids. And we know that most people, of the current cohort of people who are using heroin or using synthetics, the first opioid that they used was prescription opioids. So if we stop that, then we could stop the downstream effects in terms of heroin and synthetics. So I think it's a combination. It should be both regulation of the pharmaceutical industry and doing something about the illegal market. Yeah.
And I think that brings us to the healing community study. It's a very nice segue.
Yes, my friend. So now that, Robin, now that you have the mic, why don't you tell us about the healing community study? Because you have the most fascinating background.
Well, thank you. So the Healing Community Study is a it's a multi-state clinical trial that's funded by the National Institute of Drug Abuse, known as NIDA, which is part of the National Institute of Health, NIH. We're operating in 4 states, New York, Massachusetts, Kentucky, and Ohio. And we're targeting 67 communities in these 4 states, 16 of which are here in New York, which is where I'm based at Columbia University. And what we're looking at is a community-based approach to solving the opioid epidemic. So obviously, while I certainly agree with points made by my panelists and the importance of these regulatory issues and pharma, the Healing Community Study is about how do we make change happen at the community level to solve a public health crisis, which we're hoping what we learn in this study can be spread and scaled to address any public health crisis that's happening in a community. What we're looking at is what needs to happen in a community to mobilize a community,
to make the best decisions possible to address this crisis? How do they gather and use data to inform their decisions? As John shared, we know the medications that work to treat this disorder. We know the evidence-based practices. The study is not about trying to figure out what are the treatments that work. This study is what we call an implementation science study, where we're trying to see why is it that a community of stakeholders that care a lot about the issue are having challenges to implementing these evidence-based solutions. So why is it that a doctor isn't prescribing one of these medications that John spoke about? Why is it that providers are perhaps over-prescribing these medications? What are the stigmas that are happening in a community that are barriers both for individuals to come to treatment as well as for providers to offer that treatment?
If I may, what do you define as a community? Or yours is a very practical study, so how
Right.
exactly is a community?
That's a great question. So for the purpose of the study here in New York, we're defining for the most part a community as a county. We're implementing our project at the county level through the health or mental hygiene departments in a county. There are a few counties that are quite large, and in those counties we're targeting a particular town. Other states, in the other 3 states, it's not always a distinct county. Everybody is defining a community a little bit different, but I think that's an important question. It's not, for our research project, it's obviously necessary to strictly define it, but in the real world, when whatever we learn in this study and want to spread it, I think it's up to a group of stakeholders. They can define themselves how they want to define their community. That's what community-based participatory research is all about. A group of people coming together and identifying the problem themselves and feeling empowered to come up with solutions. And what is the secret sauce, so to speak, that's necessary? Because we know right now there are a lot of communities, and I'll speak for New York State, because that's where we're based, but it's in all of the states, everyone's aware this is a crisis, the opioid epidemic. And for many years now, communities have been trying to get ahead of this. There are task forces, there are coalitions. You can go on the web, you can see this. In many communities, counties, towns, you can find a meeting of a task force. And yet, despite many committed people sitting in rooms like this together in meetings monthly and talking about the problem and trying to implement solutions, they're not able to get the numbers down. And the question is, why is that? And that's what this study is trying to find out. We want to help a community identify, what it is that's needed to mobilize and engage so that we can hit our target of a 40% decrease in opioid overdose deaths over 4 years.
So what have you found so far?
Well, what we found is it's certainly challenging to mobilize this study. We have just about started. We're just started. We just got funded in April or May, so we're officially launching in our communities on December 1st. So right now we're in what we call phase 0, or our pre-launch activities. So we're getting to know our counties. We're working with our county commissioners. We're just about to start doing what we're calling a landscape analysis, where we're looking at what are the existing resources in a community, how many treatment providers are there, what does the criminal justice system look like, is there a coalition, what's the makeup of that coalition. So we're getting the lay of the land, so to speak, and then starting on December 1st, we're going to go into the counties, start meeting with the coalitions, and working on a community engagement model with them.
So why did you decide upon this approach? Why did you decide to take this particular philosophy of treatment?
NIDA did call it the Healing Communities Study. So,
How did you arrive at this healing communities?
I think, I believe that the feeling is that these types of problems really can only be solved at the local level. That in the end,
Are there evidence of other public health problems being solved by such an approach earlier?
there are models. So the intervention that we're using in this study we're calling it the Communities That Heal, the CTH model. There is a model called Communities That Care that has been very effective, the population was a little different. I believe it was adolescents, and so we've adapted the model to work with an adult population. And it's a bit of what we call a hub and spoke model, where the counties are the hubs and the spokes are the various providers. But it's a model that has worked but has not been tested at this scale. Yeah, we have some other panelists.
Perfect. Why don't
Should we give up our seats to the others? Or?
yeah, we can move. You can all three be seated. So if you want.
Pass the mic.
I think it'll be to the next set. And Lars also. Donna, Lars, and Robin. No, Donna, Lars. Yeah, the order changed, yeah.
I mean, I can wait. Josh.
Yeah. No. It's Donna. It's so perfect. So well, this is the second half of the discussion. The other three panelists are right behind. They'll take questions too. I will introduce Donna very quickly. She is a professor of global public health and a professor of population health at the School of Medicine, New York University. She has experience in tobacco, alcohol, and drug use at the NYU School of Medicine. Again, she is extremely qualified, has worked in all kinds of centers, has been funded by the National Cancer and Drug Abuse Institutes, the Healthcare Research and Quality, the Centers for Disease Control and Prevention, and so on and so forth. Correct me if I'm getting anything wrong. I can stop there. Excellent. Lars is from the University of Oslo, and he's the head of the research unit of Akershus. Is that correct pronunciation? Okay. University Hospital. He is a specialist in psychiatric and clinical pharmacology and toxicology. And he also holds a position as professor of Oslo Metropolitan University of Oslo. Again, rich experience. He has been a frequent lecturer in national education programs for psychiatrists and general practitioners. And we have John Rostrosen. Is that? Oh, that's you. Sorry, Josh D. Lee. Josh Lee. He's the associate professor of Department of Population Health, School of Medicine, NYU. We have a lot of NYU people, and his research is on addiction pharmacotherapies in primary care and criminal justice populations. And he's conducted NIH trials, clinical trials in the use of naltrexone, buprenorphine, opioid, and alcohol treatments. And these are all things I don't know anything about, I must confess. Perhaps I'm getting the pronunciation wrong. So without further ado, I'm going to give the mic to the panelists and ask them questions instead, which is the easier bit of my job. Excellent. So Lars, the question for you is why informing policymakers is vital to public health? Because you come from Norway, and they tell us a bird that flies over, a migratory bird, tells us that Scandinavians have got public policy fine-tuned to the T. So educate us about how you educate them and what are the lessons from the Norwegian clinical trial.
Thank you, and thank you for inviting me to this press conference today. I come from Oslo, Norway. We have a different kind of health system, but many things are similar to a number of states in the United States. My issue is that politicians and decision makers don't read scientific journals. Imagine when I write something in JAMA or when you write something in Lancet, they don't read it. And that's why and that's why we have to inform them. That's actually the very simple reason. So what we have done in Norway, where we've done this study on opiate addiction treatment that we started in 2009, and we have informed politicians and decision makers already when we performed the study that we have a study in progress and we have a hypothesis to achieve this and that. And then when the study's over, and at the same time as we are submitting this to international reviewed medical journals, we inform them again of our findings. And by that, we actually gives them the key results that they will not get hold of unless they have any secretary or any lobbyist that by chance have read our paper. And we have done that very simple, that we have actually just asked for a 15 minutes meeting with the minister or the secretary of the minister or with members of parliament and with health officials. And then we have just spent 15 minutes like in a Congress, you know, we have had kind of 10 minutes presentation, 5 minutes for questions. And that's a format that is very suitable for politicians because they pretend to be very busy all the time. And I think that will be also for what they can actually absorb because they are supposed to be jacks of many trades. So they can absorb that. But our experience in Norway is that we have managed to get through all the way to the policymakers and the decision makers by this repeatedly short information lectures, or I think that's a very good thing. Another aspect is that was touched upon here is that when it comes to how to apply any new method or any new treatment, we cannot always rely on the pharmaceutical industry or the manufacturer, because perhaps we have discovered something that will not have the great commercial interest. Perhaps we have found something that is interest for a few thousand people, not millions. And the market will be too lean, to put it that way, to actually put up a registration procedure or to marketing it. In that case, it's extremely important that we inform policymakers and decision makers, because we have to put this forth. I think we have a societal responsibility and a societal task to inform the authorities that we have actually here a cure, or we have a procedure, or we have something that we have done that has shown is more highly efficacious for a group of patients. And that these patients actually deserve to have this better treatment, even if it doesn't represent any big market or any big profit for any company.
So, correct me if I'm wrong, what you're saying is that researchers must organize and must act as a check on manufacturers, and part of doing that is to go out aggressively and inform and in some ways even influence or lobby politicians.
So I can take an example. Unfortunately, long-acting naltrexone is not registered in Europe for a number of reasons. But I've been on with my repeatedly information meetings that they are now actually taking up in Norway if this should be used in Norway on what we call passionate use, that we can use it without being registered. Because there are a number of opioid-dependent individuals in Norway that could profit from it. So they are now in a process of evaluating if this could be a choice for a limited number of patients. And I think that's a very good example how you can, by this slow but continuous process, reach to the decision makers that can actually even decide to bring in a drug that is not approved in Europe. And I think that's a kind of ultimate, if we succeed that, it's kind of ultimate proof that we can reach in to these officials. What kind of product were you? Well, I'm just talking about the product that both Joss and John and I have been working on for many years, the expert trial, where they had this long-acting naltrexone versus opioid agonist, and we did the same kind of trial in Norway. It's an antagonist, where we just antagonize the receptors. And this is completely unknown in Europe for a number of reasons. Sorry? Yeah. So we try to implement that because we think that there's a number of patients that could have a better life, that they could have a new start. They could have a recovery if we could offer it to them. But that would be kind of outside or beside the regular procedure. So that's just an example of what you can gain, by this repeatedly information to the decision makers.
Donna, I will build upon what Lars said. What are the lessons that Norway has for the US? Because Norway is a small country. It doesn't have the same sort of money in politics and the demands on politicians' time as India does or US does, or any bigger democracy does. India is very analogous to the US in that sense. And so in that case, what are the lessons that are applicable, and what are the other measures you'd have to take in bigger democracies which lack the social cohesion and the same education levels?
So, I work in a field called implementation science, and Robin referred to it. And my interests are, I'm a very pragmatic investigator. I want to understand sort of the basically we have this huge gap between what we know and what we do. And my job as an implementation scientist is to close that gap. And what was interesting about what you said is that, so one of the example of an issue with this is that you get the policymakers to agree to do evidence-based policy, which is very hard because they're influenced by politics, by, election cycles. Someone in Kingdon, I think it was British, came up with this model and talked about these three, sort of streams of influence. And one was the window of opportunity, and there is clearly one here. But once you get that drug into your country, then what? So we have it in place, and so those are the kinds of questions that we have to ask and answer. You can't stop almost, and where implementation science comes in is very useful, is to sort of start to ask. The work just begins, frankly, when the drug comes into the country, because you're going to hit the same problems we have, which is how do you get them implemented into practice? How do you get them accessible to people? What are those barriers? And we think about them and every country has these multiple levels of barriers or drivers of practice change and adoption of evidence-based practices or evidence-based treatments, evidence-based community approaches. And so whether you're in India or elsewhere, so you've got to deal with policymakers, then you're going to deal with the clinicians, you're going to deal with communities, distribution streams, industries. And so it's important to you sort of embrace the complexity of these issues, because if we don't, we're not going to ask the right questions. And to look at this as just a problem that doctors aren't prescribing, or that policymaker may not have actually chosen the right policy, ignores the interrelated nature of this very dynamic system and process. And so the work that we do too is, what's interesting about it is it really is a dynamic process. We have to keep learning, have this cycle of learning. So we put something in place, and and we find out, in fact, gee, it didn't work the way we thought it was going to work. We thought if we just gave doctors the right to write prescription for bupropion, they'd all jump at the chance of doing that. And in fact, that's just not going to happen. But why? Why? And what motivates physicians probably in the US is probably very similar. I work in Vietnam. It's very similar, actually. And Vietnam is a completely different political culture. But it's kind of, what are the incentives? What's the training and the capacity? Is it easy? We want to make it easy for clinicians and patients and policymakers to do what's right. And we don't make it easy always. We make it very complex. And so one of the things that we need to do, which is happening, I think Healing Communities, what Robin's doing is fantastic, because it's really going to the stakeholders and saying, what's going to work for you? And people are grappling and jumping, trying to figure it out. And I'll just end by saying, there is, one of the things about implementation science is the approach is to take a more systematic approach to this. Understand the barriers, the needs, the biases, those kind of things. And then come up with strategies to address those.
So what are the right questions in the US context?
I think the questions are, basically for the physicians, which is I work a lot in healthcare systems, is just why? I mean, why? What are the issues? What's the problem with? Why can't you integrate this treatment into your practice? And what kinds of incentives do you need to do that? What kinds of support in your practice do you need? What kinds of training do you need? And you can think about it as sort of I think Nora Volko in a paper I just was reading thinks about it as cascade. I think about it as workflow. And what we think about is we ask them questions along each of the steps. So if, the ED is going to start to initiate buprenorphine, you're going to ask, you need to ask, okay, patient comes in to the emergency department. What happens then? What's next? Who screens them? Who provides the initiation? Who's going to make the referral for treatment? And who's going to make sure they get there and they retain you? These are sort of the questions we ask, not only the providers, but we ask the system. We ask these systems questions about, their environment. Providers are just people. They live in an environment that affects their behavior. And there are steps along the way. And one of the things we do a lot is this idea of this workflow analysis to sort of really see how this is going along the way. And then, obviously the same approach could be said about, naloxone in the community. Well, what's the distribution mechanisms? Who's going to get this drug? What's going to happen after the patient, an individual gets the drug? Where are they going to go? How are they going to get treatment? I think it's, again, a very pragmatic approach to just understanding the steps in sort of a process and then asking questions at each step in terms of the stakeholders. How is we going to make this happen? Who should be involved? Who needs to be trained? And what are the,
And once you have answers to this, who makes the decision? Who makes the decision to implement? Because you can do a perfect study.
Yeah.
And you can have an entire systemic blueprint. But then at the end of the day, someone's got to pull the trigger. So who's going to do that?
I think, unfortunately, leaders in health systems and organizations have very short attention spans.
Who are these leaders?
So it might be the medical director of a clinic, or it might be the CEO of Langone Medical Center, or it might be, but usually it's really at a more local level that the levers get pulled. Certainly in a practice in a community, certainly these health centers, safety net centers that we work in, there's some kind of director who does that. Also, sometimes the policy levers are really important too. I mean, if the state says to get reimbursed, you need to screen for, substance use or opioid use disorders or tobacco use, they're more likely to do it. And so it's really leadership who does it, but they have to be incentivized too.
Who incentivizes them?
It keeps going up the chain, right? So, yeah.
I mean, eventually,
Yeah.
There's got to be a decision, because ultimately there have been occasions when you've had either great reforms done by a parliament in a particular country, or by a social reform movement, or by even a president by decree. I mean, after all, national parks were created by Teddy Roosevelt. So ultimately, there's got to be something coming together. Otherwise, then we have a thickening of processes and we are lost in process.
Well, we have too much autonomy in this country. I mean, when I worked in, community health centers in Vietnam, they do what the Ministry of Health tells them to do. That's who drives, policy and practice. In this country,
are you recommending a Vietnam?
Yeah, I'm recommending a social republic, but there are limitations to that as well. But yeah, I mean, someone has to make the decision that this is going to be priority. But in our backyard, and here a lot of our experience has been, it is driven by financial decisions, and where sort of reimbursement and kind of those kinds of initiatives. Now, fortunately, the government is more and more looking at it's something called value-based payment, trying to link payment to quality of care. And I think that's a good move in the right direction if we can actually figure out how to define quality of care, which is not that easy to do. So if this, for example, things might change. If suddenly providers were being reimbursed based on whether they screened for opioid use disorders and actually treated. That could change things immediately, actually. So, you know, there are things, it comes back to policy. It does come back to policies. You know, humans react in, you know, interesting ways to you know, with carrots and sticks. So, you know, providers we know that audit and feedback actually changes providers' behavior. If you give them the bad news that they're doing worse than their colleagues, they actually start to do a little better. So there are lots of these strategies, you know, to use. We don't have time to go through them, but this is what I said. But what you're pointing at, though, is a good. The point is that I think you're trying to make, and which I was saying is, it has to happen at every level, right? You know, if a doctor actually wants to prescribe buprenorphine, but their patient doesn't have access to insurance, what are they going to do? So it does. We have to push those levers at each level of society, and.
Now that we have different sections of society, you could talk about incarcerated ones, because that's a huge percentage of this country.
Yeah, decreasing. So happily, the era of mass incarceration, which still exists, is getting a little better. Incrementally, year by year, the kind of incarceration rates in the United States are lower and lower. In a city like New York, we have fewer people in jail overnight per capita, really since the 60s, which is about when we started to ramp up our kind of modern incarceration system at both the local, the state, and then at the federal level. But the intersection with the opiate epidemic is that in a city like New York, we've always had kind of inner city heroin. Our jails and prisons have dealt with it in some ways very progressively and as kind of models. Here in the city of New York, we've had methadone in our jail system since the 70s. We have all 3 of the FDA-approved medications for patients who prefer them or need them at the jail level, which is your local county lockup. Once you're sentenced to a felony in any state, you're generally then a prisoner. You'll then have an incarceration period of 1 year or longer. And then it varies by state, but all 50 states run their own prison systems, and they all vary widely in terms of what they do with opiate use disorders. And then there's the Federal Bureau of Prisons, which runs a couple 100,000 people a year. That's Bernie Madoff and federal prisoners, and they do even less probably than any state system for opiate use disorders. It's probably, though, the action is at the jail level where people are there for a short amount of time. They're there long enough to detox off opiates and then get right back out on the street, use again, but have no tolerance, and that's very dangerous in terms of overdose risk. And there's a lot of churn. So while a jail here in New York City has about 8,000 people a night in it, those people are there for a short amount of time, and many people are there multiple times a year. So the actual volume of people coursing through a jail system like in New York City is more like 5 to 10 times what the kind of daily census is. And if all those people are opiate users and they're frequently there, but only there for a week, and they lose their tolerance and then they get out again, you'll see that the city's overdose rate is tied to its incarceration rate, in that it's a huge risk factor for people dying of overdose. So we're seeing a lot across the country and at the local level, kind of like we're talking about with Heal Community Studies. Each county jail in New York State and really throughout the country is under a lot of pressure. Because of the county task force and because the governor now has to, say they're going to do something about opiates, it's a good place to start, to screen people, to offer treatment, to distribute naloxone, so on and so forth. It's only, though, a small part of the puzzle if the overall fabric of the state is, a lack of insurance coverage for these medication treatments, and a lack of availability in terms of where you would go to get that. So you know, it's one thing that it's near and dear to me. It's, I think, a bullet point in the overall discussion about the opiate epidemic. It can be a really great place to start treatment for people that otherwise weren't thinking of it or didn't have access to it. But it's got to be kind of part of the overall kind of county, state, and federal solution, which, you know, back to what we've been saying, starts with insurance coverage and larger policies and reimbursement. And why doesn't the federal government commit $100 billion to staff up, you know, treatment centers in every county or zip code? We haven't done anything like that in terms of like a real kind of Peace Corps type solution to this problem. It's more been kind of, oh, let's declare a national emergency. Let's, you know, have a few kind of PR type things. Let's distribute money to a place like NYU in terms of research, which we're all very grateful for, but really isn't getting more patients directly into treatment, which you kind of have to do overnight. Other things I would just tie together from this discussion is, why doesn't Europe have fentanyl? You know, like some of these international comparisons, we prescribed a ton more opiates in this country. That set everything off. Europe didn't do that. But there's pain and deindustrialization in Europe. There's also been heroin in Europe for, you know, centuries. Why haven't they gotten illicit fentanyl? Or is it there, but it's just not quite the epidemic that we've seen? And then I would say also, this is kind of a illegal drug epidemic in that it's now driven by heroin/fentanyl, and we've never been able to control drug epidemics through government policy. We couldn't control crack cocaine. We weren't that great at heroin, you know, in the 60s when this all started. That's kind of been the case with drug epidemics writ large throughout history. They tend to kind of come and go, though. And so one thing we're wondering is, you know, does this kind of burn out naturally, or does it become multi-generational? Again, get back to kind of like crack cocaine. The children of crack users in New York City largely did not themselves become crack cocaine addicted young adults. They kind of avoided it, which was great. And then we saw less and less of it, and we still have a problem with crack cocaine in New York City, but it's largely moved with this band of adults who are now in their 40s, 50s, 60s, and not so much younger people. With heroin and fentanyl, it's not clear how it's going to go, but you know, so far it seems to equally affect younger, older adolescents on through, you know, retirement age. So it's been a problem really for every age group, and it's unclear though if that's a trend, if that's a new thing, if it's unlike anything we've had before, like crack cocaine, or what. But what about Europe? Why isn't there a lot of fentanyl in Europe right now?
We do have fentanyl in Europe, and we have it in Norway, but I mean, regarding what I said, you know, a few minutes ago, we have been very active towards the press. And we have told the press to please, you know, print, you know, articles and bring out headlines on how dangerous it is. So we have, to a certain degree, succeeded in frightening off the drug addicts from using fentanyl. You die immediately. You know, we really went quite tabloid on that one. And I think that the only reason I can think of is that we actually use newspapers in a successful way. Well, this battle is not over, but I mean, the first round we kind of, you know, staggered them or we motivate them to not use fentanyl. So I think we had a handful of deaths of fentanyl in Norway for the last 18 months.
So if you want to publish articles on fentanyl on Fair Observer, you're welcome to, or any other topic. So that's an invitation for you to write articles for a broader audience other than your medical journals. Yes, you have a... Yes, please. We still have a few minutes, so we'll have questions from the audience and comments from the audience before wrapping up.
More patients die from alcohol and die from mistakes, thousands medical marijuana is 0. 29 states that have brought medical marijuana into legality. All of the opioid numbers have dropped, the abuse numbers have dropped. Medical companies are starting to...
The vaping crisis has probably killed one marijuana user by now. The vaping crisis has killed one marijuana user.
Okay, but medical marijuana doesn't have to be vaped. You can use drops, you can use capsules. Okay, and I agree with you about the vaping, and we're not sure if it's from the medical marijuana or from other ingredients, but I agree that there's other ways of getting medical marijuana. The other thing is that the first patient that I had came to me, and he had colitis, very bad colitis, very painful. He was taking a lot of medication, and I put him on medical marijuana. He came back a month later, and I said to him, "How you doing?" He said, "I'm off all my pain medication. I never felt so good in my life." And I went, "Really? This is my first patient." I have seen it over and over again with cancer patients, with PTSD patients. I treat patients who have MS, patients who have migraines, patients from all the conditions in New York. There's probably about 10 different conditions that are approved so far, and they keep approving more. You can buy fentanyl cheaper, enough to kill you, cheaper than you can buy McDonald's drug. So all of these things that are said are absolutely true, and I think all of these programs will be helpful because I think you have to educate people, and I think you have to start with real programs. Medical marijuana is not the answer, but medical marijuana certainly helps, and it is becoming more and more popular, and it's being done by physicians who have trained in it. I never thought that I would prescribe it. The reason I prescribed it is my secretary sent me to a meeting one day. She said, "Go to Javits Center, there's a meeting." And I was fascinated by it. And when I came back to my office, I started to practice it. I've been practicing it for 3 years. I just think it's a great medication. I think it's an alternative. It may not be the answer, but certainly it's a huge, huge start in getting people to make some changes. And I don't disagree with anything that's said here. I think everyone has said things that are very, very valuable. I just think this is another component that people should start to think about in a realistic fashion.
Thank you. Anybody else? Yes. Yes. I didn't notice you. I'll come to you. Yes, the lady there.
Thank you so much for your comments.
Would you like to wait for the mic? Or you come to
Thank you so much for your comments. My question is, much of what was discussed today dealt with the provider aspect, government regulation, advertising, but not much has been said on the public perspective. For instance, there is a great deal of public awareness that heroin is highly addictive, and yet the numbers have been fairly high, and it's certainly part of the epidemic. It's not for lack of information or awareness or awareness that it's bad and impactful. So what kind of engagement should be done with individuals to create alternatives to that demand that is not strictly medical, and also in terms of non-medical treatments for pain management?
Should I can be brief. Yeah, so the Healing Community Study is definitely taking a look at that. One of the key components of the intervention in the study is a communications campaign. So we are going to be looking at the impact of anti-stigma campaigns, of campaigns around education for consumers, for providers, for family members around available treatments, and we're going to be studying the impact through an evaluation of that communication in our counties. So that's one piece. But the idea of alternatives, another component of the study is provider education around appropriate pain management, and part of that will be, of course, alternatives to opioid prescriptions for the management of pain. We know there are successful programs out there where patients are treated in other ways that are successful. critical. So as Donna said, it's top down, bottom up. You know, it's this real systematic approach. It's not just about policies. We have to engage individuals who are receiving the treatments. The family members, the people who use opioids are critical members of our stakeholders in this study. Who am I supposed to ask? Oh, Donna, did you want to?
I was just going to ask Robin another question. I'm assuming, and I hate to do that, but I would hope that Suffolk County is one of the counties that's being looked at, because Suffolk County is #1 in the state in terms of opioid overdose deaths. And yeah, and just.
Did you want to ask another question?
Well, just to add that we're part of that particular county. We're on a reservation out
In Shinnecock? Yes.
Shinnecock, and
Yes, it's the Native American community.
years we've had over 4 overdoses within a community of about maybe 600 people.
Right. Yeah, the east end of Long Island is a hot spot. So I don't know whether to say congratulations, but yes, Suffolk County is one of our counties, and particularly the focus is Brookhaven. Given the size of the county, the study asked to focus, and there was a lot of analysis of the overdose death data, as well as other population statistics as outlined in the grant from NIDA, and Brookhaven was one of the selected communities. But there are a lot of efforts on the east end of Long Island, and particularly the Native American community around the state. Our state substance abuse agency called OASIS actually did a very targeted communications campaign over the last couple of years for the Native American community. And just sort of circles back a little bit to what Donna was talking about, but one of the things that tends to motivate providers, on top of everything that you shared, is some more personal connection. You know, there's a sense that this might not be my problem to solve as a provider, and one of the techniques that's used through communications campaigns now is to have real people, real faces, real stories, both for the providers and for the general public, so you can see that this isn't somebody else's problem. You know, this is happening in my neighborhood, my community, my next door neighbor potentially can be somebody who's suffering from an opioid use disorder.
I've had a request for 2 quick questions, please, both at the same time, and then we draw it to a close. One from the gentleman here and one from the lady here, and both of you ask your questions one after the other.
I'll be very brief. And I've lived on Long Island, and so I don't think I consider any part of Long Island to be rural any longer in the context of my question. So I'm wondering where the lines are drawn, if lines are drawn, between rural and urban populations, which often has equivalency with educational aspects. And I'd like to know where decisions are made, or when decisions are made to recognize treatment or addiction that's based on distress, emotional distress, job-related. Someone mentioned, I think it was Magda mentioned, factory closing versus actual pain related to medical treatment or an accident, some physical actual pain as opposed to an emotional distress issue. How do you organize the treatment and the responses between what I consider to be 2 different issues?
Another question, very quickly as well.
Yeah, quickly. I'd like to ask about the cultural aspect of this epidemic. I'm from Japan, and it seems to me that American people tend to be intolerant to pain, and the doctors easily prescribe pain medication. If I get the wisdom tooth taking out, the doctor prescribe opioids so easily. So this, tendency of doctor, physician prescribed medication so easy, and also the American people's tendency to be intolerant to pain. How much do you think that kind of aspect would contributing to this epidemic?
Thank you. Thank you so much. So we have two major questions, one urban-rural divide, and of course the cultural roots of this problem. What a great question to end on. Thank you so much. sure you make, but please be quick because we are wrapping up now.
The point that I was making is if you can treat people that are taking opioids for any of these conditions and get them off because they want to get healthy from the conditions, then we can use medical marijuana to help get people off of the opioid crisis, period. That's the first thing. The second thing is there is an opioid abuse law that we have in New York City, and at this point, physicians are only supposed to give 7 days' worth of opioids at any particular time. I saw a patient this morning who's getting 240 pills a month. 240, that's 8 pills a day. And we find this because there's a national data bank and you can see who's getting what. So the idea was that to try to think of using medical marijuana as a tool, if you can get them off of their condition and where they're using the pain medication, then it should be used to help to get people off of addiction. I mean, a lot of people are against it. I worked with all the doctors in New York City, and I mean thousands of doctors because I've written letters to them. And a lot of them in the beginning were against it. More people are open to it. And it's just a point I'm making. I'm not telling you it's the cure for everything.
Cannabis may be a good alternative treatment for pain, you know, non-opiate management of chronic pain. That will be very interesting, and we hope to see it. We certainly hear a lot of anecdote, and it'd be great to have better studies. It's certainly not a treatment for someone with a heroin addiction to help them get off heroin and stay off heroin that we know of. It would be a miracle if it were, but we'll see in terms of studying medical cannabis. I would just say to that, it doesn't really, once you're addicted to heroin, it doesn't really matter if it started with pain or it started with your childhood trauma or the factory closed or your dad was a heroin addict. The treatment approaches are very similar. It's, you know, you use a type of medications and hopefully some type of counseling. But then to relate to the patient and really to kind of make sure it sticks, you probably want to pay attention to all that stuff. And for instance, if someone has severe PTSD that's not treated and that interlinks with their addiction, you can treat the addiction and not get very far until the trauma is addressed. So that's a classic example. Or I'm in chronic pain, I'm still in chronic pain, you know, my neck is fused and, you know, my bone spur is this or that. Like you will still have that thing you'll have to deal with. And if you don't kind of address a plan for that while also treating the pain pill addiction, you'll probably be less successful than otherwise.
Just to address your urban versus rural community, for the Healing Community Study, that was one of the requirements from our funder, NIDA, that we had to have a mix of rural and urban. Half of the 16 communities had to be rural and half, I believe, had to be urban, and that was as defined by the federal government. So one might look at the map and see the counties and perhaps disagree with rural versus urban, but for the most part, I mean, most of our, other than Suffolk, the counties are all mid-Hudson and further upstate in western New York, so we are hitting a fair amount of rural areas as well as in the other 3 states. It's quite rural. Yes, cultural. Yeah. Someone want to address?
There's a growing evidence that opioids doesn't work in chronic pain. We had a paper out this January where we looked at chronic pain in opioid-dependent individuals, and when we blocked the opioid receptors, what happened? Nothing. The pain was not influenced by blocking the opioid receptors. That's the ultimate challenge to prove if opiates have any effect or not. So those who had pain still had pain. Those who had no pain still had no pain. That's one thing. Secondly, the use of opiates lowers your pain threshold due to some complicated mechanisms that I will not comment on here, but we do have evidence on that. So the more opiates you use, the more pain you get. We call it allodynia. So when you quit opiates, your pain threshold actually increases. So we know that, but just now we have a study running in Norway. We're going to pinpoint just that question and kind of prove it. So it will come out in 9 to 10 months. Yeah. So your question is that yes, it's a cultural thing. I think that Americans are used to have a kind of better service, a faster medical service that kind of used to be served in a more sufficiently than the Europeans or the Japanese. I mean, to go to a doctor in Norway 50 years ago, you must be very close to dying. Yeah. You know, or some very, very serious thing. So even in Europe, you know, the kind of threshold for seeking medical advice has come down. But I think there still is a kind of cultural difference. Yeah.
I think it's like a consumer product. Yeah. Medicine here. That's different.
Nancy has one final.
Just a quick question, because you are addressing, obviously, on a personal level or individual level, but it was brought up in the beginning panel that this is also financial. And what are you doing, or what can be done, to take away the initiative, the incentive, with our government, who takes encouragement from the big pharmas, to the doctors that take heavy doses of encouragement from the big farmers? What are you going to do? What can you do besides, in order to influence the end of that?
Turn over prescribing? Yeah. I mean, the insurance won't reimburse, or the threshold for getting a prescription is much higher now. That automatically starts to limit. Prescriptions have dropped per capita since like 2011, right? But they're still pretty high.
But it's harder to prescribe now. I mean, if you go into Epic, for example, I mean, you have to go through, you know, several levels of checking the patient's history of prescribing. I mean, you can't, it's not as easy to prescribe, which is going to make it a higher threshold for physicians to actually give this drug to, hopefully, to the person who really needs it. But yeah.
And I think, given what we know about the opioid epidemic at this point, the threat of lawsuits against physicians who are overprescribing is really very much of a disincentive. I mean, you know, when you, yeah, I mean, the largest prescribers of opioids a few years ago were dentists who were prescribing for third molar extractions, wisdom tooth extractions, and they were prescribing large quantities and giving the prescription to people before they, I mean, these are all, you know, kids in their adolescence, giving them prescriptions to be filled for 30 tablets or 60 tablets before they actually had the surgery. So they'd fill them, and you don't need anywhere near that number. And you can develop tolerance and some dependency within 2 or 3 days.
But not everybody who uses will develop a dependence, right? It's a small minority of people who will use opioids, who will use prescription opioids and then become dependent. And so it depends on a whole other host of issues going on, right? Like, for example, past history of trauma, past history of depression, anxiety, post-traumatic stress disorder. A lot of other things play. It's not just you use opioids, you become addicted. Just one more thing I wanted to say about the financial incentives. I think one other issue with financial incentives that we didn't discuss is that at the same time that prescription opioids were pushed as the solution, there was also a disincentivizing of other alternatives. So there was basically no insurance coverage for other types of alternative treatments, like physical therapy, for example, that could have been effective to treat chronic pain. And so I think part of the discussion about how to treat chronic pain effectively and the financial incentives should be about insurance's role and the coverage of other alternative treatments.
Yeah. No, I was just going to make a slight distinction between dependence, which is really a physiological function, and addiction, which is a behavioral function. And everybody who takes opioids is going to become dependent, just like somebody who has diabetes may become insulin dependent. But that doesn't mean you'll be addicted. I mean, people can stop taking opioids. They will, once they're dependent, they're going to have withdrawal when they stop. And it's not pleasant to go through that withdrawal. But a lot of people go through that withdrawal and don't become addicted and don't continue to use. So.
wanted to say something.
No, I was just saying, you know, I was thinking about the tobacco industry that you brought up. It's a very different type of product, but, you know, we learned a lot about how to regulate that industry very effectively. So there are, you know, and we're doing that now. What I think is interesting about what you just said, Magda, is we have to be careful because policies always have unintended consequences. And so we never think about what that might be down the road. That's it's an important thought experiment that we have to help policymakers make, because they're not going to do it on their own. But I just want to bring that up because I think that's really what you were.
Just one, in my regard, important thing. Why do the majority of chronic pain patients report that opioids work? Well, not everybody. In the majority, they say that it works, even it doesn't work, but they report that it works because opioids gives an emotional distance to the pain. We have done in-depth interviews by a number of pain patients, and they, when we interview them really, really thoroughly, they say that it's the distance to the pain. They can carry the pain because the pain is not in them. They kind of carry the pain outside the body. And that sensation is what they report to the medical doctor, says, oh yes, it works very well. So I think that's very important distinction. So if one can have a good dialogue with the patient, say, listen, it doesn't really work, but you feel better. If we could, reduce that and either take it away or search other strategies like marijuana or non-opioid analgesics, that would be a good strategy. But I think it's important to mention that because you can't just say that if a patient has pain, you can't say, no, it doesn't work. Because that would kind of shut the door completely for any further, insight making in the patient. But to get the patient to conceptualize that it's only just they make a distance to the pain.
Thank you, ladies and gentlemen, for being such active participants. I, at least, am leaving the room enlightened and educated. I hope some of you are. Give everyone here a big hand. And without further ado, I call this evening to a close, and I hope to be in other such evenings in the future. Thank you for giving me the honor of hosting this. Have a good evening, everyone.